Welcome to this explainer. Look, today we're tackling something that is absolutely high stakes and incredibly urgent. We're talking about clinical stroke recognition and response. Because let's face it, when a neuroemergency actually strikes, you don't have time to sit there and second guess yourself, right? You need clear, completely actionable information that you can just pull from your brain in a split second. And really, that's exactly what we're going to build today. So let's just dive right into the medical logic, the mnemonics, and the critical steps that literally save lives. Okay, to start things off, we have to establish our absolute baseline definition. I want to create a mental anchor for you, right here, right now. At its very core, a stroke simply means stop the blood. Honestly, if you remember nothing else, that is the one sentence you need. No matter what specific type of stroke we're dealing with, fundamentally it's an interruption. Blood is just no longer getting to where it desperately needs to go in the brain. And it's that exact lack of blood flow, that starvation, that triggers literally every single symptom we're about to unpack. Here is our roadmap for today's explainer. We're going to start with the mechanics, move into spotting a stroke, then mapping the brain, finding the causes, and finally wrap up with time is brain treatment. Let's jump right into section 1, the mechanics. Before we can even think about spotting symptoms or looking at treatments, we really need to understand the physical reality of what's happening inside the skull. And it's actually fascinating to look at the sheer contrast in these statistics. We basically have two main possibilities when the blood stops. On one side, we've got ischemic strokes, and these account for a massive 85% of all cases. On the flip side, making up that remaining 15%, are hemorrhagic strokes. Having the statistical baseline in your head, knowing that almost 9 times out of 10 you're dealing with an ischemic event, gives you a huge immediate edge in anticipating what's likely happening with your patient. To make this instantly understandable, I love using the simple plumbing analogy. It hits the nail right on the head. Imagine the blood vessels in the brain are just water pipes. For the 85% of ischemic cases, you simply have a blocked pipe. A clot lodges in there, it blocks the flow, and it literally starves the brain tissue of oxygen. So blocked brain equals ischemic. Now, for the 15% of hemorrhagic cases, you've got a burst pipe. A blood vessel actually ruptures, and it leaks this high-pressure blood directly into the delicate brain tissue. So burst brain equals bleeding. It really is that straightforward. Blocked versus burst. Keep that exact image in your mind as we move forward. Moving on to section 2, spotting a stroke. So how do we take that internal plumbing failure we just talked about and instantly recognize it from the outside? You've probably heard of the classic FAST acronym, right? Well, we really need to upgrade that. We're using BFAST now, and this is absolutely crucial. Before you even check the classic FAST symptoms, you need to check the B and the E. That's balance problems and eyes, which means looking for sudden vision loss or double vision. A lot of subtle strokes get missed because people skip those two. After that, then you move to the classics: face drooping, arm weakness, and speech problems. And that final T, that's time. Time to get emergency services on the line immediately. So remember, the major takeaway here is to always check balance and eyes first. Now, if you're in a highly chaotic environment and BFAST feels like just a bit too much cognitive load to juggle, here is a rapid-fire alternative for you. The 3 Fs: face, force, and fluency. It's super quick. Is their face normal? Do they have normal force, meaning is there any arm or leg weakness? And do they have normal speech fluency? If literally any of these 3 Fs are abnormal, you don't wait around, you immediately think stroke. It's a brilliant little mental shortcut. Let's dive one layer deeper with section 3, mapping the brain. This is where it gets really cool, because we can actually use these outward symptoms to figure out exactly where the damage is happening inside the neuroanatomy. We broadly divide the brain into left and right hemispheres. And the easiest, most reliable way to map this in a clinical setting is the simple rule: left talks, right sees. The left hemisphere largely controls language. So if a stroke hits there, you're going to see aphasia, trouble speaking or understanding, alongside right-sided body weakness. Remember the crossover. Now, the right hemisphere controls recognition and spatial awareness. So a stroke there causes something called left-sided neglect, where the patient might completely unconsciously ignore the entire left side of their world. And that comes alongside left-sided body weakness. Left talks, right sees. Beyond left and right, we also have to map the brain from front to back, looking at circulation. Anterior or front circulation strokes are usually what give you those classic face, arm, and speech issues. But posterior strokes, those affecting the back of the brain, they look completely different, and they are so easy to miss if you aren't paying attention. For posterior, you absolutely must think of the 4 Ds: dizziness, diplopia, which is double vision, dysarthria, meaning slurred or uncoordinated speech, and dysphagia, which is difficulty swallowing. If a patient presents with the 4 Ds, you are almost certainly looking at a posterior circulation issue. All right, section 4, finding the causes. What are the hidden culprits that actually trigger these emergencies in the first place? Let's break it down by our 2 types. For ischemic strokes, remember our blocked pipe scenario. We use the mnemonic CLOT. C stands for carotid artery disease. Plaque buildup, breaks off, and goes to the brain. L is for left atrial clot. I want to highlight this one because atrial fibrillation is a massive, high-yield driver of these strokes. Blood pools in the heart, clots, and shoots straight up. O stands for other emboli, like those come in from infected heart valves. And finally, T is for thrombosis, where a clot just forms right there locally in the brain's artery. Ultimately, a clot is either traveling from somewhere else or forming on the spot. So that's the blockage. But what causes the burst pipe? For hemorrhagic stroke triggers, we pivot over to the BASH mnemonic. B is for blood pressure. Specifically, we're talking about uncontrolled chronic hypertension, which just puts immense wearing strain on those fragile vessels over time. A is for an aneurysm, which is basically a structural weak point, like a ballooning in the vessel wall that finally gives way. S is for stroke due to anticoagulants, meaning blood thinners, or underlying bleeding disorders. And H is for head trauma. These are the primary aggressive forces that will cause a vessel to physically rupture inside the skull. Now, overarching all of these specific triggers are the general long-term lifestyle and health risk factors that basically set the stage for both types of strokes. You can remember this with the acronym SHADES: smoking, hypertension, atrial fibrillation, diabetes, elevated cholesterol, and a sedentary lifestyle. It's a pretty straightforward way to look at a patient's history. If a person is figuratively wearing these shades, you know right away that they are at a highly elevated risk for a stroke event. And that brings us to our final and definitely most critical phase, Section 5, Time is Brain, which covers our treatment protocols. I really need to emphasize the sheer gravity of this concept. Time literally equals brain. Rapid recognition and treatment, they don't just gently improve outcomes, they entirely dictate them. Let this sink in. Every single minute that an ischemic stroke goes untreated, it can result in the permanent loss of roughly 2 million neurons. Millions of neurons gone every 60 seconds. You are quite literally racing the clock to save the patient's mind and their future quality of life. Because we are on such a tight clock, the treatment sequence has to be rigid. For ischemic strokes, it goes CT, then clot, then cure. Step 1 is, and always will be, a non-contrast CT scan to definitively rule out any bleeding. You have to know what you're dealing with. Step 2 is clot. Once you're sure there is no bleed, you consider thrombolysis, giving them those strong clot-busting drugs, assuming they fall within that strict time window. And step 3 is cure, where we consider mechanical thrombectomy. That's a procedure to physically go in and yank the blockage out, usually reserved for patients with a large vessel occlusion. Now, I mentioned step 1 was a CT scan to rule out bleeding. Why is that step 1? Because of this, the absolute golden rule of stroke medicine. Never, ever give thrombolysis until an intracranial hemorrhage has been excluded. Think about our plumbing analogy. If you give intense blood-thinning clot busters to a patient who actually has a burst pipe, a hemorrhagic stroke, you aren't fixing a block. You are making an active bleed absolutely catastrophic. It is a massive, unmissable rule. The CT scan absolutely must clear them first. No exceptions. So, what if the CT scan does show blood? Well, then you know you're dealing with a hemorrhagic stroke, and your treatment pathway shifts immediately to the STOP protocol. S, you stop any anticoagulants they might be on, often giving reversal agents if appropriate. T, you treat their blood pressure aggressively to reduce the physical force of the bleeding inside the skull. O, you operate if indicated, maybe calling neurosurgery to relieve the rising pressure. And P, you prevent secondary complications, things like raised intracranial pressure or dangerous seizures. With a bleed, the focus shifts entirely away from clearing a pipe and straight into aggressive damage control. To synthesize this entire explainer, let's pull it all together right here. We have the ischemic stroke, the blocked artery, causing about 85% of all cases. With these, the initial acute CT scan actually often looks completely normal, and your main clinical goal is reperfusion, getting that blood flowing again. Then you have the hemorrhagic stroke, the ruptured artery, making up the other 15%. Here, the blood is immediately obviously visible on the CT scan, and your primary goal shifts to controlling the bleeding and managing that dangerous pressure. Blocked versus burst. It's the core narrative of everything we've talked about. We've covered the internal mechanics, the neuroanatomy, the specific causes, and those highly urgent treatment pathways. But at the end of the day, it all cycles back to that initial recognition, because when that clock actually starts ticking and millions of neurons are quite literally on the line, will you remember to be fast? I highly recommend you lock these mnemonics into your memory today, because at some point, they are going to make you the deciding factor between a patient's devastating loss and their successful recovery. Thank you so much for joining me for this explainer. Keep reviewing, stay sharp, and I'll catch you next time.